I'd like to introduce our speakers for the keynote session. A Long Time Coming, The Standard of Care Framework and What It Means to Pharmacy by Scott Drabant and JoAnn Stubbings. Scott Drabant is the current Director of Government Affairs, the Government Affairs Division at ICHP. He obtained his Bachelor of Science degree from Utah State University and his Bachelor of Pharmacy degree at Creighton University. JoAnn Stubbings is Director-elect of the Government Affairs Division at ICHP and Clinical Associate Professor Emerita at the UIC Retsky College of Pharmacy. She was formerly the Associate Dean of Specialty Pharmacy at UI Health and currently works for the Department of Pharmacy Practice. JoAnn is a member of ICHP's Specialty Pharmacy Network and has served in specialty pharmacy leadership roles at ASHP. Please join me in welcoming Scott and JoAnn.
First, I'd like to state that neither JoAnn, I, or Chris have any conflicts of interest to report. Today, we're going to talk about some learning objectives. We're going to describe the challenges and transformation of the practice in Illinois and nationally. We're going to define what standard of care is and how it applies to pharmacy and other health professions. And then we'll apply it to a series of case studies reflecting practice in Illinois.
And I wanted to point out that as we talk about standard of care, I wanted to emphasize that it is a regulatory process that we're going to be talking about that is part of the Pharmacy Practice Act, but it's not going to be boring. We're not just going to be talking about regulations, because this is something that has the potential to change the practice of pharmacy. It's already starting to happen across the country, and the goal of it is to align the regulations or the Pharmacy Practice Act with the current and future practice of pharmacy. So it is a regulatory process, but it is something that's relevant to all of us. Yeah, so we're going to talk about a few cases throughout, and this is not a polling question, but I just wanted to kind of set everybody up by going through 5 different services, and just think to yourself, which of these following pharmacy services are permitted by the current Illinois Pharmacy Practice Act. Number 1, strep throat test and treat. Number 2, cholesterol test and treat. 3, assessment, consultation, and dispensing of hormonal contraceptives. 4, therapeutic interchange. And 5, dose modification. So just think about these answers, and we'll come back to this later in the presentation.
Okay, JoAnn, let's show our colleagues a path for elevating the practice of pharmacy in Illinois to a higher level, whereby pharmacy professionals can practice at the top of their education, training, and experience. I mentioned those 3 words. You're going to hear them a lot: education, training, and experience. It's the core of standard of care. When we refer to pharmacy professionals, as we will in this presentation, we're referring to both pharmacists and technicians. There are 2 basic regulatory models that can go out there. Currently, Illinois Pharmacy Practice Act operates under a bright line regulation model. It is a clear, ambiguous rule that dictates specific actions and prohibits behaviors, leaving little room for interpretation. This is the current Practice Act. It tells us what we can do, what we can't do, where we practice, what the room needs to look like, and everything in detail. As opposed to that, there's a new model that's being utilized out there. It's called the standard of care. What it means by standard of care is the degree of care a prudent and reasonable licensee or registrant, that's everybody in Illinois that has a license, with similar education, training, experience will exercise under a similar situation.
Okay, so the current Illinois Pharmacy Practice Act, we can define may versus can, and may refers to what the current Pharmacy Practice Act allows pharmacists and technicians to do, versus can, which is what the pharmacist can do under a standard of care sort of regulation. And where we are right now with the bright line, it's kind of like a box in that pharmacists are restricted by what the legislature determines can be in the Pharmacy Practice Act. So whenever there's a new service that we want to pursue, we have to wait for it to go to the legislature, be voted on, and then that gives us the permission to do the service that's being provided.
Like JoAnn said, technically speaking, the current Pharmacy Practice Act in Illinois, if it does not specifically address what you can do, you're not allowed to do it. As opposed to standard of care, and we'll get into this more of what it allows you to do.
So the standard of care, as defined previously, reflects what the pharmacist with the education, training, and experience can do. So you've got kind of a transition then from what the Pharmacy Practice Act currently allows to what standard of care would allow. And our hope is that we can close the gap from the restrictions of the current Pharmacy Practice Act to a standard of care environment. We'll talk later about the states who have already made this transition in their Practice Act, but that helps to reflect what the pharmacist is trained to do.
Let's talk a little bit about the pharmacist patient care process.
Yeah, so the pharmacist patient care process, and anybody who's a 20-year graduate of colleges of pharmacy was trained in this. And there's a disconnect between the PPCP and what the Pharmacy Practice Act allows. So as you know, that the pharmacist patient care process was developed in 2014, and it's currently under revision in 2024. The final version hasn't yet come out, but it's got 5 different steps: collect, assess, plan, implement, follow up, which is monitor and evaluate. And some of the activities that are typically things that can be incorporated into the pharmacist patient care process are test and treat, collaborative practice agreements. Obviously, this is very important in team-based care, therapeutic interchange, refill authorizations, delegation to technicians, administer medications, adjust doses, and most importantly, team-based care. So the premise of the pharmacist patient care process is to incorporate pharmacists into team-based care through all of these different activities. So you can see that there is a disconnect between what the current Pharmacy Practice Act allows and what you as pharmacists and as technicians are trained and able to do in practice.
So what we're saying, JoAnn, is that standard of care is not one size fits all.
Yeah, I mean, the current Practice Act is kind of one size fits all in that, regardless of your abilities, you've got certain things that you're allowed to do. So
okay,
go ahead.
Let me explain this slide. It's kind of busy, but hang in there with me. On the bottom, the green bar, it's the line across the bottom. That's the entry barrier. That means you passed the MJPE and the NAPLEX test. You're licensed. The 3 bars represent 3 different practitioners. The red line at the top is the practicing at the top of your license. That's what the current Practice Act allows. Now, practitioner A is practicing at that level. He's practicing at it. Now, practitioner B can only practice to that red line, but say that's a pharmacist who did a residency, became board certified, and is working, say he did a residency in cardiology, is board certified in cardiology, and is working on a cardiac unit. He has training and experience greater than what the legal ceiling is allowed. Now, practitioner C may be a pharmacist who was working in an institution and got into IT and has been in IT for a number of years and is really not at the top of his game as far as practicing at the top of their license. This is what the limitations of the current Pharmacy Practice Act, which is referred to as Bright Line, what it restricts what you can do.
So are you saying that this red line then is the Bright Line regulation?
That's the Bright Line. That's the ceiling, the glass ceiling that you can't go above. what our Practice Act tells you what you can do and what you can't do. In contrast, when you have a standard of care framework, everything is the same. The minimum competency is there. The legal top of your license changes. Pharmacist, practitioner A practices at that level and is there. Practitioner B, now that has the extra education, the extra training and experience, can practice up there. And practitioner C practice at the level that their experience and training allows them to do.
So it goes back to the standard of care being reflective of the pharmacist's education, training, and experience, right?
Those three magic words you're going to hear a lot.
Okay. Tell me about the Illinois Pharmacy Practice Act, the current one.
Kurt, wow. I know most of you have read it and you had to go through it, and there's a lot in it. But in our current Practice Act, it allows for administration of vaccinations and extended opiates. We can do test and treat. We can do hormonal contraception, HIV, PEP and PrEP, medication management, and MTM services. Some of these, the ones with the asterisk, need some sort of appropriate training along with it. Our act is long.
And it does, you notice on the point of care test and treatments, or actually what we're trying to call diagnostic tests and treatments, it does even specify the ones that are allowed. So influenza, COVID, strep, RSV, lice, those are the conditions. And the asterisk does specify where additional training needs to happen. So we're really bright lined. Like if we want to do these things, we can only do them within the context of what the Practice Act allows. Plus, we have to demonstrate that we got additional training, even if you've had this, if you've got the capabilities, you have to demonstrate that you did this training in order to be able to perform this service.
Going along with how long it is, on the first one, administration of vaccinations and immunizations, in our Practice Act, it's almost 450 words long. It just goes on, where it can be simplified under a Practice Act if you have the training, experience, and education. In comparison to, say, the nursing regulations, Pharmacy Practice Act is a lot longer. The word count has grown over time. It's the most restrictive, and we've taken a divergence from nursing. We have more words in Brightline laying out specifically what you can do and what you can't do. Nursing took a different path, and they have fewer words in their Practice Act, and they can do more. So it's kind of subtraction by regulation and adding in qualifications. Not necessarily that length means a lot, but it just shows how much more restrictive we are and how much more words there are in there. We have approximately 80% more words in our Practice Act than in the Nurses Practice Act, or actually it's 97% more in our Practice Act than the nursing, and 105 more than the physicians have in theirs. So this divergence has expanded. So with nursing, they've added responsibility by subtracting words out of it, giving more latitude of what they can do. In the Nursing Practice Act, there are 0 words on immunization and vaccinations. In the Medical Practice Act, there are 0 words on Immunization and Practice Act. It's understood that they have the education, the training, and experience to do this. And that's kind of where we want to go. It's an evolution, but there's all the other medical professions go under a Standard of Care Practice Act.
Yeah, so I did want to point out that this slide that you're looking at is based on research that was done in Idaho. So Idaho was one of the 3 states that have adopted standard of care regulations, and this is kind of what they used to demonstrate that kind of pharmacy has been divergent from nursing and medicine. So as you can see from this, when you go to the standard of care regulatory framework, it reduces the size of the Practice Act, and it simplifies it, and it makes it more flexible, and it gives you the ability to accommodate new practices without having to go through a long legislative process. Okay, let's start with the first question. So we're going to have assessment questions throughout to kind of help you, think about and see how this applies. So a standard of care regulatory framework results in a Pharmacy Practice Act that is longer, more detailed, and more restrictive, or longer and more complex, or shorter, flexible, and less detailed. And the final answer, shorter and more restrictive. And the answer is shorter, flexible, and less detailed, and that is correct. So most people got it correct. So I think a few people answered A, and the bright line is longer, more detailed, and more restrictive, where standard of care is shorter, flexible, and less detailed. Talk about the other definitions, Scott.
Okay, where does standard of care come from? It's not something that JoAnn and I thought up, and it comes from a number of organizations, and we'll show you later on a number of states that work. NAPP, the National Board of Pharmacy, and that's the definition that we'll probably be using here most of the time, is the degree of care a prudent and reasonable licensee, pharmacy professional in Illinois, with similar education, training, and experience will exercise under similar circumstances. NIH, National Institute of Health, also adopts this standard of care. It's a treatment that is acceptable by medical experts as proper treatment and widely used by healthcare professionals. In other words, same thing, education, training, experience. And let's not leave out the AMA, the American Medical Association. It's a measure of duty practitioners owe a patient to make medical decisions in accordance with what other prudent practitioners treatment on the same condition a similar patient would be. So it goes back to similar education, training, and experience.
So the stakeholders, there are stakeholders in this process, and these are organizations that have formally developed policies to support the standard of care framework. And so American Pharmacists Association is an important stakeholder, and they developed a policy. They passed a formal policy, I think it was in 2022, and I've highlighted a few parts of this policy. So first, they recommend the standard of care regulatory model, and they request that state boards of pharmacy and legislative bodies regulate pharmacy practice using this model. Then secondly, they reaffirm their policy that encourages state boards of pharmacy to dedicate the following: resources, independent authority, and assistance in meeting their mission to protect the public. And finally, third, the APHA encourages the National Association of Boards of Pharmacy to support and collaborate with state boards of pharmacy in adopting standard of care. And then finally, they say that stakeholders should provide educational programs, information, and resources. So, for example, what we're doing now, kind of educating people on what the framework is. Another important stakeholder is American Association of Colleges of Pharmacy, and they also have specific policy and guidance. And so AACP again urges boards of pharmacy and legislative bodies to adopt the standard of care regulatory model. They encourage colleges and schools of pharmacy to add it to their curriculum. So we're hoping that this is going to be taught in colleges across the country. They encourage colleges and schools of pharmacy to work and collaborate with their state boards of pharmacy in implementing the regulatory model. And finally, they encourage the colleges to provide educational programming for pharmacists.
As you can see from what JoAnn just said, this is national organizations that are embracing this and encouraging it and wanting the states to move forward. Especially like with NAP, that's the National Board of Pharmacies. So the boards are saying, this is the route we need to go.
Yeah, which is ahead of where we're at right now, but
Right. So it's obvious the question comes up when you talk about standard of care or changing. What about provider status and payment for service? They kind of go hand in hand with standard of care. Currently in Illinois, we are not recognized in statewide and federally, we're not recognized as healthcare providers in the true sense. If you look at our Practice Act in the definition of pharmacist and the practice of pharmacy, provider is not mentioned. If you dig back through those 70-some pages, you'll come across the MTM section, and in there it states provider, but it's with qualifiers that it's got to be under a protocol or certain criteria. We want the ultimate provider status where we can bill Medicare and insurance companies for our service and get paid commensurative what other health professionals are getting paid. Not something that's tagged on to a dispensing fee. It needs to be something good. Standard of care can provide that because it's going to give us greater latitude in what we can do based on your skill set as far as education, training, and experience. Now, provider status, we go on that, are we a provider? Back in 1965, Medicare recognized various health professionals as healthcare providers, physicians, nurses, and then subsequent over the years, other professionals, healthcare professionals were recognized. Clinical psychologists, optometrists, marriage and family therapists, nurse midwives, but not pharmacy. 1965, that was 59 years ago. It's time we're recognized as healthcare professionals, both in the state and federally.
Yeah, I think everyone agrees with that.
I hope so.
Yeah.
And then, the question that's going to come up, and it's probably going to come up from legislators, well, if we recognize pharmacists, healthcare providers, is that going to, in reorganizing, is that going to cost the state money? Well, the answer is yes and no. There may be some additional costs secondary to the optimization of medication therapy, but this will be offset by a reduction in the cost of avoidance and reduction in hospitalizations. Numerous journal articles are out there expounding on the fact that pharmacists save money. For example, in Illinois, as noted in the Pharmacy Practice News back in February of 2020, pharmacy-led initiatives save millions. Another study confirms the same results, and a study at Memorial Medical Center in Springfield, right here in Illinois, saved almost $1 million, $840,000, without adversely affecting clinical outcomes.
So just to summarize, these are related concepts, but they're distinct but related. And standard of care is definitely in line with our push toward provider status and payment for services. But also these things set the stage for team-based care, which is basically the premise of the pharmacist patient care process. So how will a standard of care model be incorporated into the Pharmacy Practice Act?
Well, that's interesting, JoAnn, because we're changing the whole paradigm from a bright line regulatory enforcement model to a standard of care. So different things take place in that, and with the bright line enforcement model is what we're currently under. If you violate one of the rules or the regulations that are in there, you're held to a strict line of breach of your care. And they include disciplinary action based on the violation of the specific state regulation. A standard of care model is broader. It's evaluating the pharmacy professional, because it goes to both provision of clinical service to a patient instead of a detailed prescriptive protocol. Standard of care is the treatment of another that would be given by another reasonable practitioner in a similar setting. It's going to be a little bit harder on the Board of Pharmacy on this. So basically what it's probably going to come down to is a hybrid. There are certain things that are going to have to stay under bright line. Control, regulation of controlled medications. That's certain state and federal laws regulate that. And then the hybrid will be looking at the clinical practices, and are they based on what a pharmacist would do with their education, training, experience, similar to what another practitioner would do under the same circumstances?
So you're saying that the hybrid would have like bright line. We're going to have bright line for operational procedures, dispensing procedures, but for clinical services that require a lot more, flexibility, then that would be more of a standard of care model. Similar to nursing and medicine, where their professional services, they don't bright line every single thing a physician is able, may do. They actually say the physician would practice in accordance with the standard of care.
Exactly.
Right. Okay.
It's gonna be a little bit harder on the Board of Pharmacy, and it's gonna be a transition. It's not gonna be an overnight transition. It's gonna take some time.
Yeah.
And you'll have to work one into the other.
Yeah. Okay. So let's try another assessment question. Adoption of a standard of care framework involves A, boards of pharmacy, B, colleges of pharmacy, pharmacy associations, or all of the above. And it looks like everybody got that right.
All right.
So that's
We're doing good, though.
great.
So you ask, where is all this coming from, and where does it start from, and how does Illinois compare to other states as far as a standard of care? There are 3 states out there now that have standard of care: Idaho, Iowa, and Alaska. Iowa was the last one they just implemented, and they're in the process of changing their Practice Act to a standard of care. They're the innovators. Then there's the early adopters, the early majority, the late majority, and those that lag behind. Where's Illinois on all this? That depends on everybody. This is going to be a whole project. JoAnn and I had the opportunity to go to a symposium in Idaho to see what's happening in their state and how they're doing it. There were 17 states represented at that thing. And that's just the states that attended the Iowa one that we know that are going in this direction. I'm sure there are many other states that are looking at this. As far as other states that are looking at it, I know California is looking at it, Virginia, Washington. So there's a whole number of states that are looking at how they do it. I would like to see Illinois is that we're in the early adopter or the early majority. It's going to take some time. We have to do a lot of education, not only of our colleagues, but also of legislators, regulators, the Board of Pharmacy, the department, on how we're doing this and how it'll work.
Yeah. I would say that the appeal to legislatures on going toward a standard of care is that it decreases the amount of regulation. It simplifies the Practice Act. So what happened to Iowa, and actually that's our next slide, the way they got it passed, they were pushing for standard of care for like 2 or 3 years and wasn't getting any traction. And then their governor put out a mandate, or just told every association or board within the state to simplify and shorten their practice acts. And so that was the opportunity for Iowa to take their standard of care model that they were trying to get through and put it through as the simplification of their practice act. And I think they got it approved within weeks. So their Practice Act is 26 pages long, which is a lot shorter than Illinois'. They did one thing is they defined the pharmacist as a provider along with some of the other providers. They also specifically defined what a pharmacist does. And they define this under the section on pharmacist license. So they say a pharmacist may dispense, administer, monitor, and issue prescription drugs, biologics, medication orders commensurate with the pharmacist's training, education in accordance with the appropriate standard of care. The other thing that they did bright line into their prescription regulations is this really interesting extra clause: a pharmacist may exercise professional judgment by refilling a prescription drug order without prescriber authorization in accordance with the appropriate standard of care. Wouldn't that be nice?
Yeah.
Okay.
Okay. The general principles that Iowa used in determining if a service or an action by a pharmacy professional violates the Practice Act is it prohibited somewhere else in the Practice Act or in other laws or rules within the state? Is the service consistent with their training, education, training, and experience? Is the service in accordance with accepted standards of care that would be provided by a similar pharmacy professional by a reasonable and prudent licensee or professional with similar education and experience? So they lay out the groundworks of how they're going to determine if it violates it. And it goes from there. Now, I think on our next slide, we list some more of the states that are contemplating going standard of care. Okay, we were talking before about the other states moving towards it. Like we said, Idaho, Alaska, and Iowa. Iowa's got it in their Practice Act. But look at all the other states. About a third of the states are now contemplating going to a standard of care. And if you look at the states, they're all over the map, not figuratively, but population-wise, political orientation. We've got every mixture in there. They're all looking at it. So I think this is a great movement. This is a national movement that's sweeping across the country as far as where pharmacists want to go, where they see their future in healthcare.
Okay, great. So what we'd like to do at this point is delve into some cases. So let's go back to the first, one of the first slides that we presented. And so this is not a polling question, but just, first to consider which of the following pharmacy services are permitted by our current Pharmacy Practice Act. Strep throat test and treat, the answer is yes. Cholesterol test and treat?
No, but it would be under standard of care.
Okay. Assessment, consultation, and dispensing of hormonal contraceptives?
That's kind of a yes and no. It's in the Practice Act, but the rules haven't been released yet. So it's kind of in that cusp in between.
Yeah, so you can see how we're kind of at the mercy of Brightline here because we had to wait years for this to be passed, and now we're waiting for the rules. Therapeutic interchange?
Not yet in Illinois under the current Brightline regulations, but under standard of care, that would be accepted.
And dose modification?
No, but there again, under standard of care, if you're dealing with a patient, taking care of a patient, and you notice the dose needs to be modified, either they're having side effects or problems with it, or it's something that needs to be tapered up, you could modify that dose.
Okay. So now let's go into some assessment questions. So these are cases. And so the first one is a certified pharmacy technician has the training and experience to transmit medication refills to another pharmacy. And the question is, the pharmacist may delegate this function to the technician under a standard of care regulatory framework. True or false?
Okay, JoAnn, let's see what the survey says.
And most people said true, which is correct.
It is currently done under the Practice Act. However, I may add in there under the standard of care framework, there would be more latitude in what could be delegated.
Okay,
Let's do another one.
Let's do another. This is a rural hospital practice setting, and the pharmacist is a recent PharmD and completed a PGY1 pharmacy residency at a rural hospital in Illinois. The pharmacist has the training and experience to offer discharge medication management services, including dose adjustment that meet the needs of the community, prevent readmissions, and help to improve access to healthcare in the rural area. Question is, the pharmacist may perform these services under a standard of care regulatory framework. True or false? And the answer is true, and that is correct.
Yes. This is the core of standard of care. That pharmacist is working within his skill set, his education, training, and experience. Some may say that hospitals have protocols and you don't need to have standard of care. Yes, but what you're trading is one box for another. Under a protocol, you have more latitude of what you can do. For example, say in your specific institution, you're allowed to dose, say, PCA pain management. Your patient is not a metabolizer of morphine. What do you have to do? Contact the prescriber again. Can I change it to whatever is your second agent in your facility? And that may take time. In the meantime, that patient is suffering. or if the patient is now recovering and is eating food and can take oral meds, then the PCA should be discontinued, get that line out of there to avoid infection, and switch them over to an oral agent. That's what standard of care would allow a pharmacist to do, give them more latitude in that.
And you would still have protocols, right? I
You'd
mean,
have
this is
protocol.
not saying it would take the place of protocols
No.
or CPAs.
No, protocols are nice and they give pharmacists a lot of latitude, but you're still in a box. You're still limited of what you can do, of what that protocol states you can do. Whereas standard of care, you can take care of the patient according to what is the current standard of care in a similar situation.
Okay, so let's do a specialty pharmacy case. A pharmacist and 2 technicians work in an outpatient pharmacy dispensing discharge medications. They want to offer medication management services for patients with cancer who are taking oral oncology medications. The services would include adverse event management and dose adjustments. The pharmacist would delegate outreach clinical assessments to the technicians. So the question is, pharmacists and technicians may perform these services under standard of care regulatory framework, true or false? The answer is false. And let me explain the reason, because in this case, it's very brief, but I think that in this case, the pharmacist and that whole area would need to demonstrate that they have the education, training, and experience. And in the area of specialty pharmacy, there are standards and there are accreditation standards and things that a pharmacy would need to do to be able to demonstrate that their pharmacists and technicians can perform the clinical assessments and the things necessary. And if those things happen, then the answer is true. Then the pharmacist and technician would be able to perform that. But as the case is written right now, it's not clear that they have the necessary training and experience to be able to do it. So it wasn't really a trick question, but we knew it would be difficult.
Let's talk about like a retail setting. Do we have a question on that?
We do. This is a pharmacist weight loss medication management. So pharmacist owns and manages an independent pharmacy in the suburbs of Chicago and has been in practice for 25 years. There's a need in the community for education, training, and medication management for weight loss. The pharmacist recently obtained a weight management certificate from ASHP. The question is, pharmacists may perform these services under standard of care regulatory framework, true or false? Most people answered true, and we would agree with that because in this case, the pharmacist, by having the weight management certificate and by being in practice for 25 years and having the experience with the community, would demonstrate that they have the necessary education, training, and experience.
Well, I think
Comment?
I think they're getting the hang of it.
I think so.
Let's look at some takeaways.
Okay, so the key takeaway for this presentation is that the standard of care framework allows pharmacists and technicians to practice in accordance with the standard of care and commensurate with their education, training, and experience.
Yeah, as you can see from all the case studies, the standard of care removes the pharmacy profession from the regulatory box or jail type we talked about before, and allows them to practice at the top of their skill set, which is their education, training, and experience. Standard of care provides an opportunity for pharmacy professionals to prevent medication-related side effects, improve patient outcomes, increase access to healthcare services. Other benefits of standard of care is it's flexible. As new technology comes out there, we can adapt to that without having to go to Springfield to ask the legislators, can we do this? It's compatible with future advances in healthcare. It's proactive and progressive. It's greater integration into a team-based care setting. we need to work with them. Let's do a couple more assessments just to make sure everybody has a good understanding here.
Yeah, these are the last two assessment questions. And the first one is a definition, a clear, unambiguous rule or standard that dictates specific actions and prohibits specific behaviors, often leaving little room for interpretation. Is that a bright line regulation, healthcare provider, pharmacist patient care process, or standard of care? And the answer is bright line regulation. So almost everybody got that correct. And so let's go to the last one, which is the level of care and service that a reasonably competent and skilled health professional with a similar background in a similar setting would have provided under similar circumstances. Is that bright line regulation, healthcare provider, pharmacist patient care process, or standard of care? And
right.
yep, I think we're there, Scott.
I think that we're getting the hang of it here.
Yeah,
Yeah.
that's it.
Okay, so now where do we go from here? I just want to make one point before we go too far in this one. Both Brightline and standard of care are regulatory models. So standard of care would replace a lot of our Practice Act. It would still have to have some Brightline parts to it, as we mentioned before, like with controlled substances, with who can dispense medications. Brightline, just to kind of do a synopsis here of it, it's what our current Pharmacy Practice Act. This is exactly what you can do. This is what you can't do. Kind of like the rules of the road. When you get that book from DMV, this is what you can do. You got to drive on the right side of the road. You got to turn this way. You can't do that. It has advantages. It protects the public. And that's the premise of the Pharmacy Practice Act from the legislator's point of view, is that it protects the public. It's easy to administer by the Board of Pharmacy, leaves little room for interpretation. Disadvantages of the Practice Act is that it requires legislative action to change anything, and things changed. We just came through COVID, and there was a lot of changes that needed to be made, and they needed to be made overnight by standing orders from the Department of Health. With standard of care, that wouldn't have been necessary. We could have easily and we will step up to the plate with that. It avoids the delay between the law being passed and the rules being written. And that makes a lot of difference what you can do. Over-regulation a lot of times blocks initiatives of patient care and public safety. Pharmacy laws compared to medicine and nursing and the other healthcare professionals tend to be a lot more restrictive. They're newer, and they need to be amended more. Standard of care would eliminate a lot of that. Standard of care, on the other hand, also protects the public I believe to a greater extent, because it allows pharmacy professionals to practice at the top of their skill set. It utilizes the competency and ability of healthcare professionals. The scope of an individual practice, it depends on their skill set. What is their education, their training and experience? Recognizes the homogeneity of professionals, advances new education, technology, and science and standard practice. It avoids linking fixed regulations to an entire class of professional. One size does not fit all. Some people aspire to do more and have gone on for extra training and experience. Others don't have that desire. That's okay. You can do what you want under standard of care. You just have to stay within your skill sets, your education, your experience, and training. It avoids the long statutory regulatory process. If you want to know more about that, join government affairs. If they said watching legislation is like making sausage, that's a mild comparison. Getting legislators to agree on something is like trying to herd cats. It just doesn't work well. It leverages pharmacy standard of care, leverages pharmacy to support safe, effective, optimal medication use, and affords greater protection to the public, allows pharmacy professionals to practice at the top of their respective education, license, and experience. Big disadvantage I can see is not for us, the Board of Pharmacy. It's going to be hard to regulate. It's going to be more of, how did this compare to another person? So they're doing a comparison rather than the law says and you must. They have to evaluate it. So it's going to be a little bit of interesting in that way.
Thank you both for an excellent, presentation on such an important topic. We are going to open it up for questions. One, there's kind of a comment from Garth Reynolds, just mentioning in terms of provider status that there's, really three elements, right? Designation, scope of practice, and payment for services. And one of the comments is, in Illinois, we have some of those things for some aspects, right? So depending on how you want to look at it, we do have provider status in some aspects and not in others, or with certain insurers like Illinois Medicaid. And he just points out that the pharmacist means an individual healthcare professional and provider currently licensed by the state to engage in the practice of pharmacy. And so I think one of the key things that is tough is practice authority, right? Or practice authority or independent practice authority, which would be kind of like what physicians, if it's within our scope of practice and we can do it and we've been trained to do it and we have that experience, like you mentioned, truly having a standard of care would allow us, in theory, to do all those things and be able to bill insurance for them and be reimbursed for those services. So we're definitely not there yet.
No.
Another question that came up, because this is more of a question, how have pharmacies within the states that have included standard of care in the Pharmacy Practice Act been able to adapt in terms of their standard operating procedures?
Yet to be determined. They're working through the process. Iowa is just the one that actually has the full range of standard of care in their Practice Act, and they're working through that right now. And this is a point out, like we said, when we go to a standard of care, and I'm quite confident we will in Illinois, it's going to take a lot of work and it's going to take a lot of individuals. ICHP is forming and has started to form a work group that will bring all the key stakeholders together: regulatory, from the department, from the Board of Pharmacy, from pharmacists, from technicians, from legislators, from rural hospitals to big inner city teaching hospitals, to independent pharmacies, to chain pharmacies. The whole realm of everybody needs to be at the table so we can talk about this and look at the Practice Act and go, do we need to keep this bright line section in here, or can we go to a standard of care? It's going to be a process, and everybody's working through it right now. So can't give you a definitive answer. They've done this and it works. It's a process, and they're in the process right now, and hopefully soon we'll be in the process also.
Yeah. And we were at this seminar, this symposium in Iowa, and there were presenters from Iowa and Idaho, and there was a panel of pharmacists in Idaho that were actually implementing standard of care in different outpatient clinics. Like Women's Health, I think, was one of them. And I have to say that it looked pretty familiar. So anybody that's practicing in an outpatient clinic and they're practicing team-based care, that's kind of what standard of care looks like. So they were just given the opportunity to be able to implement these practices. So it can happen in a clinic setting, it can happen in a pharmacy setting. Yeah, implementation is very interesting and exciting process. And I think we've laid the groundwork here in Illinois.
I think, we're changing the paradigm, and it's sometimes when you change things like this, it makes people feel uncomfortable. Bright line to some people is like Linus's security blanket. I know what I can do. I know what I can't do. Standard of care allows you to break down those walls of that box that are surrounding you, and you can practice at the top of your education, experience, and training. I keep repeating it, but that's what it is, and that's what it allows us to do. This is not something that JoAnn and I can say, we're going to standard of care. It's not something government affairs can say we're doing this. It's not something that ICHP and IPHA can all of a sudden say we're this. This is a movement. It's going to have to be all of us working together as a movement to contact your legislators, educate them on this, educate your colleagues on this, and we need to move forward. There will be more coming from us on this, but this is the start. this is where we need to go. We're creating a movement to get standard of care to increase the practice, and I think I'm out of time.
Yeah.
There are a couple more questions that we can ask here. One is, I would presume that the standard of care model dictates that pharmacists go through a credentialing process to define what pharmacist education and experience sets as their standard compared to others. Do other states with standard of care models have similar rules dictating credentialing?
Some have, some haven't. California is a big one that has dabbled into that. Standard of care does not necessarily dictate that you would have to go through that process. It may come of that, and there's another steps you can do in it.
Yeah, there is discussion. The thought is that it would not be included in the Practice Act, but that credentialing is definitely something that could be done and in some cases should be done. And kind of like in a health system where a hospital will privilege certain providers. I mean, physicians have credentialing and privileging, so pharmacists could have the same thing, but it would not necessarily need to be in it would be just viewed as another bright line if it was in the Practice Act.
And I give more latitude to the individual facilities to determine what they want done in their institution.
So
Chris?
in terms of that, it would depend on the institution, whoever your employer is and what their requirements are, right? Because physicians, just because you're a surgeon doesn't mean you can do surgery at any organization, right?
That is correct.
So there would still be practice limits based on organizational policy. The
Correct.
other thing in community pharmacies, one of the pharmacists from Iowa who is expanding clinical services, that was one of his questions, right? In terms of what is standard of care for me? Is that I go around and I talk to the local pharmacies that are surrounding me and see if they're doing it. And if they are, that means I'm practicing standard of care. Or what is that, right? What is that standard that you have to meet to say this is okay and this is within my scope of practice?
And
There's going to be some gray.
I don't think that was completely answered at that meeting.
No. So I think there's going to be some learning, through all of this, right?
Right.
Yeah, right. Because in the example you gave, Chris, it could be like an island of independent pharmacies in an area. This is what they do, but that's not the standard across the state, across the United States of what pharmacists do. A lot of standards of care comes out of best practices and institution and organizations and universities establish standards.
Mm-hmm. The other thing to always separate is standard of care, right, is a legal definition, right?
Correct.
Versus best practice and guidelines. So standard of care is not guidelines-based practice, and it's also not, right, protocol-based practice.
Correct.
It is what would a prudent individual in your locale with the same experience, right, degrees, all the things that, Scott's phrase that he's been using, meeting all those criteria, what would that person, what types of services would they offer and what would they do? I think we're getting close to out of time, but there are a couple more questions. I want to make sure we can answer some of them. How could compensations for technicians improve with a standard of care model? Do you think technician compensation will improve?
You mean salary?
I think what they said is compensation. So I would assume salary and maybe benefits.
It should improve regardless. I mean, that's a whole different topic. Our technicians aren't paid enough, but I think anything that furthers the practice of pharmacy and the opportunity to delegate to technicians would elevate the profession and elevate salary. As their value and their contributions improve, salary should follow. And it gives us more leverage to be able to advocate for that.
Right.
I want to say thank you to Scott and JoAnn for presenting on such an important topic and a topic that I know a lot of people maybe didn't know a lot about. So I'm hoping this is part of that educational journey where we start to educate more people about what does it even mean and what could it mean for us as pharmacists and technicians. So in a few years, we can do this in Illinois like they did in Iowa.
Thank you for the opportunity of letting us present this.
Thank you.
So